Hello and welcome everyone. This combined webinar, good morning, good afternoon, good evening, wherever you are. This is a combined webinar of the Asia Pacific Wrist Association and also the British Society for Surgery of the Hand, the latter celebrating its 70th anniversary this year. I'm Matthew Brown, I'm a hand surgeon in Edinburgh here in the UK, and I'll be co-hosting this webinar with my colleague Rebecca Lim of Singapore, whom I'll hand over to shortly. So over the next 60 or so minutes, we'll feature 3 recent and top-cited papers from both the Journal of Hand Surgery European volume and also the Journal of Wrist Surgery. We're joined by the editors-in-chief of both of these papers. So Jane McEachen, editor-in-chief of the Journal of Hand Surgery European volume. She's a hand surgeon in Fife at the Fife Hand Clinic here in Scotland in the UK. We also have Toshi Nakamura, who is professor of hand surgery and the editor-in-chief of the Journal of Wrist Surgery. He works in Tokyo, Japan. He's a past president of the then EWAS, or now IWAS Association. We're also joined by the president of the BSSH, Wee Lam, hand surgeon in Singapore and Edinburgh, and a previous editor-in-chief of the European Journal. Our APWA representatives include Professor Bo Liu of China, Beijing, China. He is the current APWA chair of the Education Committee. He's a professor of orthopedics at the Sishu Town Hospital in Beijing, and he has an interest in arthroscopic and robot-assisted wrist surgery. We also have Professor Greg Bain from Adelaide, Australia. He's the APWA Executive Board member and past president of APWA. He's president currently of the Australian Hand Surgery Society. He's a professor of orthopedics and upper limb surgery with an interest in wrist arthroscopy. We also have our invited expert from Europe, Arnaud, of the Institut de Le Mans in Paris, France. She has a great interest in wrist arthroscopy and wrist and hand surgery in general. She's the General Deputy Director of the EURCAD International Wrist Centres Education and also the course director of the EURCAD IWC France arthroscopy courses that run frequently. We've got 3 papers for you today from both the European and Journal of Wrist Surgery journals. The first will be on TFCC arthroscopic foveal repair. The next will be on robot-assisted percutaneous scaphoid fixation. And the final will be finite element modeling of wrist kinematics. We have the authors from each of these papers who will present and summarize, and this will inform the discussion thereafter. I'd like to hand over to Rebecca Lim.
Okay, and good day yet again to everyone, and welcome once again to our Combined Journal Club. It is my great pleasure now to invite Wee Leon, President of the British Society for Surgery of the Hand, to give his opening remarks. Wee Leon, please.
Thank you very much, Rebecca. It is a great honor for the British Society for Surgery of the Hand to partner with the APWA, Journal of Wrist Surgery and Journal of Hand Surgery European to be part of this webinar, which I'm sure will be an extremely informative session. Thank you very much for inviting us.
Okay, thank you, Wee Leon. And our second opening statement will be delivered by Liu B, Education Chair of the Asia Pacific Wrist Association. Bo, may I invite you to share remarks?
Thank you, Rebecca. So on behalf of the APWA Education Committee, it's my great pleasure to welcome you all to today's Joint Journal Club webinar. This webinar promises to be both insightful and collaborative, reflecting APWA's mission to advance education and innovation across the Asian Pacific region as well as the world. I must thank the co-hosts, the colleagues from BSSH, JSHE, and Journal of Wrist Surgery, as well as our special invited expert Alan from France. So we are honored to have this such distinguished expert in this webinar, and I hope you can enjoy this webinar. Thank you.
Okay, thank you both for the thoughtful and inspiring remarks. With that, we'll begin the scientific program. May I now call upon Dr. Chinakat Boonyasirikool from Thailand to share your paper, please. Dr.
Yes.
Chinakat, thank you.
So, so everyone can see the slide, right?
Yes.
Okay. Good evening, everyone. Yes, I'm very delighted to invited to this webinar. Okay, so my talk today is about our study about the arthroscopic foveal repair of the TFCC by the proposed inside out technique at the specific ulnocarpal anatomical landmark, which published on during November 2025. Okay, this is our team. So we all know that TFCC attachment provided by arthroscopic is have a benefit of intra-articular evaluation with lesser dissection, with a lesser dissection than the open surgery. So, but the challenge of us is that how to accurately pressing the suture to grip the deep part of the RUL, which is the major stabilizer of the RUJ. And after we pass it correctly, how to pass the suture for the foveal reattachment. That is our question that to conduct our technique. So our previous study in 2023 is about the anatomical landmark study in cadaveric study, that we using the landmark between the base of the UL and UT on the palmar side. So we begin this suture first, and then the second one is directly opposite the first suture. So then we retrieve it out from the DF portal and check. So the result is 97% of the RUL was gripped securely at this landmark. So by this data, we want to conduct the study in the clinical patient. So we do the retrospectively review the data between September 2017 to 2020. So the diagnosis criteria is standard. So the procedure indication, what we use this surgery is that one, mild to moderate instability, which felt conservative, or the patient will come initially with a severe instability. The foveal disruption was confirmed by hook test or the direct DRUJ arthroscopy. And all of the injury was classified into assay class 2 and class 3. We exclude that the patient with the wrist deformity are not impaction or irreparable, and the patient must follow up with us at least 24 months. So for the result evaluation, we also look for the pain, functional score, grip, and motion, also the complication. So for the technical note, we use the 5 portal, V4 for 5 direct DRUJ, direct foveal, and 6R. So after we examine the joint and do the debridement, synovectomy, everything is clear. So we do the foveal preparation. So by viewing either by direct viewing at the DRUJ portal or indirectly at the 4-5 portal, then we use the instrument either by curette or a burr, motorized burr or shaver from the 6R at the foveal. So we debride the foveal footprint by this step. And then after we open the direct foveal portal, we use the direct curette on the footprint again. After foveal preparation, we do the inside-out suture passing. According to our previous study, we used a viewing portal from 3-4 and instrument, which is the suture lasso from 4-5. Okay, the first suture was punctured at the base of UL and UT, and then retrieve the suture out. And the second one is at the opposite side of the first one. After we retrieve a pair of suture out via the DF portal, we do the foveal reattachment by the mini open through the DF portal by using the push lock, knotless anchor suture. So this is a walkthrough of our operation. So patient have a severe instability, and we use the standard approach. This is a debridement one. Hook positive. So this is from the DRJ portal. Okay, we can either use using the burr to do this step, or either directly by the 6R portal. So in some case that we cannot access to the DRUJ, we use only 6R portal and 3-4. And this is another step to curate the footprint. So suture passing using 3-4 and 4-5. So 1, and then we retrieve the suture. So we got one limb, add another one, and push it out, another limb. Okay, so we have a pair of the fiber wire together, and then buried by the anchor suture. So it's stable after repair. So the result, so after all, we got a 38 patient, which age around 36. Time to surgery, which is a chronic one, that is 12 months after injury, and the mean follow-up time is 32. Majority is male, and severity is predominant more than the mild moderate degree. So most of the case is both limb of the RUL injury. So all parameters were significantly improved after the operation, including pain, function, grip strength, and range of motion. So in summary, all patients had a stable DRUJ and better function. 27 patients can return to sport at 6 months, and 2 minor complications, which is the dorsal branch of ulnar nerve neuraplasia. So the inside out and ulnocarpal ornamental landmark, which we propose, is has significant improvement in the functional outcome, and it's easy to do. So the previous study or the previous technique using the special instrument for doing the inside out, which the surgeon have to use the special instrument, which may difficult to find because it's unique one, or it's quite a large one, which can damage the cartilage. So our technique, by using the viewing at the 3-4 camera and 4-5, so this view, the instrument is not obstruct with the camera. So this camera gives you the wide angle and easy to look for the landmark what you are looking for. So it's simple, precise, and you can you do it with one attempt at the specific location what you want for. So and pushing down the disc from above, from the top, and push down to the footprint is the easy one if you do in the floppy disk. Like this. So foveal insertion through the F is another discussion point, which is technically easy. You need just a minimal dissection, no special device, and no fluoroscopy need. So without this fixation method, you can do the inside-out passing like what we do, and you do other fixation like a trunk or shear. So whatever you do, it will work well with inside-out technique. So our limitation is the no comparative study, so it's just a retrospective, so we cannot claim that this is a better one or not. So but we got a positive result from our technique, and in the series there is a small number of isolated PRUL ligament injuries, so most of our case is both limb injury. Thank you.
Thank you, Dr. Chinakat, for that wonderful presentation. I think that this paper addresses a very practical and common challenge in wrist surgery, and which is to restore DRUJ stability in patients with repairable TFCC foveal injuries. So before opening the discussion to the panel, I'd like to invite the editor-in-chief of JHSE, Jane, to comment. So Jane, this paper has clearly attracted significant attention. So from an editorial perspective, why do you think it's one of the most cited papers?
Well, it's an interesting question. First of all, I think the topic itself is a popular one, and we've seen a number of papers over the last few years dealing with various aspects of arthroscopic repair, including open versus arthroscopic, anchor versus transosseous fixation, inside out versus outside in techniques. But this particular paper gives a good step-by-step guide with reliable landmarks, which I think captures the imagination of arthroscopists and makes it easy to reproduce in other centres.
Okay. Do you think that the impact stems mainly from the technique itself, or the fact that because it remains an area where surgeons are still seeking more reproducible results?
Well, I think both, Rebecca. I think because it's a fairly popular technique, I think and this is the first time this particular technique has been described, then I think that made it a good to publish paper. However, as the author points out, there's no control group and the long-term outcomes are not yet available. So it has got its limitations, but as a description of a technique, I think it's a very good one.
Okay, thank you, Jane. Now we'll move on to for the expert panel. So may I ask Liu B to comment first, given his work in ligament-specific TFCC repair? You are muted. Oh.
I think Chinaka's paper, I think is a good one. Like Jane has mentioned, his step-by-step description of the technique and using commonly a tool that everyone can commonly easily to find. So I think it's very good to identify in this paper about how you actually really reattach the ligament back to the native footprint of the DRULs. So I think it's one of the key in the recent years to achieve good outcome of the TFCC repair. And also it's interesting to in this paper the authors mentioned about both dorsal and volar ligament tear versus just single limb, like just dorsal or just volar part of the ligament is intact. So I think we are seeing more and more partial tear of TFCC. This paper actually is quite interesting to mention about this. However, the number of the number I remember is, if I'm correct, its number is 5 for the isolate palmar ligament tear. So I think it's it's not a very balanced group between. So I think it's one of the key information for TFC repair in recent years. We need to identify the DRUL. It's not a single ligament. It's a dorsal ligament and volar ligament. They have different insertion and different origin. And looking at the footprint of a TFCC at the foveal area, it's a rather large area instead of a small isometric point. So I think they also correctly use this technique to try to reattach both ligament back to the native footprint of TFCC. However, I have one concern about this technique is about because if you use one single suture to reattach both ligament back to the native footprint, so the suture seems is the gap between the 2 points. You go to you go through the TFCC. Actually, I think it's like 4 or 5 millimeters. So sometimes we can find that the previous study have shown that the gap of the suture is about, if it's around 2 millimeter, which is it's better to achieve better mechanical outcome. So, but you use one single, so you have to span up this suture. So instead of a 2 separate suture, I think it may have problem in the patient, particularly for the patient with larger size of the wrist. And you correctly mentioned the both volar and dorsal part. But if you actually, you can also use your technique in the future to address the partial tear for the like isolate dorsal tear or isolate volar tear with just single suture, but have smaller gap of the suture. Yeah, that's my thought. Thank you.
Okay, thank you, Bo. Maybe we can now ask Dr. Nakamura, very famous, the authority for TFCC. Would you like to share a few comments?
Yeah, thank you very much, Chinaka. It's a very clever method, but to me, it's something like arthroscopic assisted repair technique. Then that can be much more reliable because I normally do an open repair and also through arthroscopic repair. But this is actually the connecting bridge between that all arthroscopic repair and that open repairs. So I would like to confirm that the tension of the suture in your technique is sometimes a little bit difficult because you use push lock. Then is there any case that can be the stitches harms the triangular fibrocartilage? Because if the triangular fibrocartilage is much more chronic and also degenerated, then that's something that to me it's a relative risk for the cutting out the TFC.
Yes. Yes, we experienced some cut through. Yes. So I think the key point is that the landmark of the suture, if you can grip the thick part of the RUL, and then you can grab it, so it will not cut through unless it's very chronic one. Okay, so we have to look for the chronicity of the quality of the disc before we suture it. You're right.
I see. Also, that I actually have data about the DLG scopes that found that 60% of the foveal aversion was a complete aversion. Then 30% was a dorsal aversion. Then only 10% is a palmar aversion of the radial ligament. So that was a very consistent with my data of your findings that the palmar aversion is much more smaller numbers. Thank you very much.
Thank you.
Thank you. And then maybe now we ask Alam, would you like to give your comments for this paper?
Thank you, Rebecca. Thank you to the presenter. It's a very interesting paper. Actually, I agree with all the comments that were previously done. I found very interesting in this study the use of the landmarks, more than the inside-out techniques, because it's very difficult from the radiocarpal view sometimes to really identify the palmar and the dorsal ligament, because you have complete white field sometimes. It's very difficult to place the sutures. I have one question. Do you think because you have good results in this study, do you think the good results are due more to the inside-out technique and the placement of the inside-out suture, or the good results are due to the use of the landmarks? In other terms, if you use these landmarks with a traditional technique, an outside-in technique or a transverse technique, would we have the same good results? Because there is a lack of comparison with the traditional techniques. Do you think that the use of the landmarks or the inside-out technique that gives the good results here?
Again, I think both of the point is the key of success, because we know the landmark, which is already know that we can grip the good grip of the RUL. And using the inside out make you confident with that landmark. Okay, so
yes, because
both of them.
Okay, so yes, actually, I think it would be interesting in the future maybe to have a comparison between this technique and a traditional other technique that using these landmarks. And do you think that would be my will be my last question for this paper. Do you think that the use of the landmarks is reproducible in the chronic tears? Because maybe in the chronic tears you have a distorted anatomy, and do you think we can reproduce these landmarks in the chronic tears? What do you think about this?
We do it some of the complex tear, but because to answer also from the Dr. Bo that so by this landmark or inside our technique, we can use this passing from inside to outside in the specific location. So if we want to repair the dorsal limb or the volar limb, we can change the location. So that's why in the complex tear, if the quality is good enough, not cut through the suture, not cut through the disc, we can choose the suture placement, maybe 2 stitch or 1 stitch. Okay.
Maybe Bo, you could answer this question. Do you have some advice in the chronic tears to choose the good placement of the suture? Do you have any advice? And do you think these landmarks are reproducible in the chronic tears?
Yes, exactly. So this is a wonderful question, Alan. So it's really true that for early chronic cases, the anatomy may not be normal. So it's challenging. I think we need a more experienced surgeon to tackle this more challenging problem. But basically, for chronic cases, because when there's like a total avulsion, the TFCC actually is floating up, and it's loss of the normal anatomy. So sometimes we need to, before we reattach the ligament back to the foveal, we need to do some release of the soft tissue so that we can really push the TFCC back to the foveal before we really do the suture. So I think a lot of things we need to take care of. So I think it's a good question. So may not, this technique is good, but we really need to know that there's the limitations. Yeah.
Thank you.
Okay, thank you. And Greg, would you like to share your comments with us?
Yes, thank you. Congratulations. It's a nice paper. From the inside out technique, I've liked the idea of using that for a long time because you can put that needle exactly where you want it with precision. So you're looking exactly where it is. Whereas when you come from outside in, there's a little bit more variability. Gary Paling was the one who actually first described it all, and I've used something very similar to his technique for a long time. But what I've found with Gary Paling's technique, you introduce the needle from 3-4, and you have the scope on the ulnar side, and you use a 2E bent needle, so you bring it around. And I found that works very well for the volar side, but I've not been able to really get to the dorsal side. You've swapped the portal and the needle to the other side, and you can do that because you're using this very angled lasso suture passer. So that's really opened up this opportunity for you. And I think that's why you can get to the dorsal part when we were struggling in the past. So I think this is actually really an advantage. The idea of using that big mattress suture we think is a good idea. And we published a technique some years ago using a similar concept, but using a ligament graft. But basically the idea was to staple it all down because the tear for instability, and this paper is all about instability actually, it's a foveal avulsion, so that enables you to do that. And so I do like quite a few of the things that you're doing with this, how you've changed that concept. So the question I really have is, because I've got to have a question for you, and it relates a little bit to what Bo and Toshi were saying about it's very common for a foveal avulsion to have a dorsal capsular tear. And I wonder whether you should be really addressing that a bit more, maybe doing your mattress suture, plus also introducing some dorsal capsular repair. So I'd just like you to comment on that.
Right. So we have yes, we experienced that too, that we have foveal tear and also dorsal tear. So sometimes we combine with foveal reattachment with capsular repair together. By by do a foveal repair first. Okay, so you can get a better shape of the TFCC, and then we can clearly see what happened to the dorsal side, and then we do the capsular repair later.
Yeah. And then the final comment is that Brian Adams, with his reconstruction, he often brings a tendon graft through about pretty well your anatomic point. So basically that ligament goes to the lunate and the other one goes to triquetrum. So I think it makes quite a bit of sense. So thank you for sharing that with us.
Thank you.
Okay, thank you. And then that was a helpful discussion. I'll now hand over to Matthew for the second paper.
Thank you, Rebecca. A great technique and a great paper to focus on. So the second paper is from the Journal of Hand Surgery European volume. It is on robot assistant percutaneous scaphoid fixation, including the patient-reported outcomes and the learning curve at 2 centers in China. So Dr. Yi is from the Sishutan Hospital in Beijing, China. So I'll hand over to you, Dr. Yi, if you share your slides.
Yeah, okay, thank you. Dear colleagues, good evening. I'm Ija from Beijing Jiutai Hospital. It's my great honor to present our study, robot-assisted percutaneous scaphoid fixation, patient-reported outcomes and learning curve at 2 centers. This study published in Journal of Hand Surgery European volume. So as we all know, percutaneous screw fixation for scaphoid fractures is technically demanding. Its complication rate could reach up to 30%. In 2019, our team published the world's first clinical case series on robotic wrist fracture fixation. The 10 case study confirmed the technique's feasibility in our hospital. However, its multi-center performance and the learning curve remains unclear. This is what our current research aims to figure out. So our primary aims are to evaluate radiological results, patient-reported outcomes, and analyze the learning curve of the robotic technique based on a larger cohort from 2 centers with longer follow-up. This is a retrospective case series. We enrolled 62 patients with acute minimally displaced scaphoid wrist fractures between 2018 and 2023. Operations was performed by 2 hand surgeons with different expertise levels. We adopted the T-report system. It consists of a 6-degree freedom. Robotic system consists of 4 essential parts: the robotic arm, the optical tracking system, the 3D fluoroscopy unit, and a surgical workstation. So the surgeons can select the optimal screw entry point and the trajectory, and verify it on multiple views intraoperative. After planning, the robotic arm automatically moves to the touched position. We assess the screw accuracy on post-operative CT scans. 2 angles, alpha and beta, alpha on the coronal plane and beta on the sagittal plane, were measured between the long axis of the scaphoid and the screw. We use a cumulative sum method to analyze the learning curve. It clearly identifies the turning point when surgeons achieve stable proficiency. So as for the results, 62 patients, the mean follow-up was about 36 months. All fractures achieved new bone union at an average of 9 weeks. No major complications occurred, and patients obtained excellent pain relief and wrist function. The first attempt success rate of guide wire placement was 97%. And the mean alpha and beta angle were both about 6 degrees. So based on the operative time, the learning curve turning point appeared at the 11th for surgeon A and the 10th cases for surgeon B. In terms of screw accuracy, the turning point were 7 cases for surgeon A and the 17th cases for surgeon B. So this study has also have some limitations. It's retrospective, and we did not make direct comparison with traditional freehand surgery. And also future further research, including junior surgeons, is also needed. So to conclude, the robot-assisted percutaneous scaphoid fixation is safe and reliable. Surgeons can master this technique after 10 to 20 cases. So we suggest targeted supervision for beginners during the initial 15 to 20 procedures. Thank you for listening. This is my presentation.
Thanks, Dr. Yi. Amazing presentation. It was really clear to follow, and it's a really interesting technique. The results are pretty impressive. You know, we all know getting that wire placement can be tricky, and 60 out of the 62 wires placed at first attempt is very impressive. I've got a question for you in terms of your ongoing practice. Do you feel that robotic assistance would be your first choice for these undisplaced or minimally displaced scaphoid fractures, or would you still be mixing with other techniques that aren't robotic assisted?
Usually in clinical practice, we usually mix the robotic technique and the freehand technique. One important reason is there's a much phase when we use robotic technique.
Exactly. And I'm going to come to Jane first. So this was published last year. It's highly cited. What do you think the merits of this paper were, and why do you think people are interested in citing it?
Thanks, Matt. First of all, thank you, Dr. Shi. That was very well presented. This is a paper that's a proof of concept. You know, all of us who fix scaphoids would love to have a 97% accuracy with placement of the first guide wire, and this proves that it can be done with technology. However, you know, everything about this paper is impressive. The setup of Jishutan Hospital is very impressive. The catchment area is very impressive. The technology that they have to use is very impressive. And I think this is a popular paper because it is the first to describe the use of a robot in wire placement, which opens the door, I think, for the next set of papers. Not because this particular paper has impressive results compared to other methods of percutaneous fixation, because percutaneous fixation of minimally displaced fractures is relatively reliable, although in the SWIFT trial, 93% of screws were found to be somehow poking out of the scaphoid one way or another. So this probably improves the accuracy. But more than that, if it can do it for these undisplaced fractures, then when it comes to recreating the technique for non-unions and complex humpback deformities, then I think it will definitely provide an improvement to our current standard of care. The problem, obviously, is the setup involved and the investment that it requires. A very impressive paper.
Yeah, absolutely. Thank you, Jane. I'll come to Arlen first. What are your thoughts on this technique? What are your thoughts on the paper? And barriers to implementation, what are your thoughts?
Thank you, Matthew. Congratulations on this study and this paper. I completely agree with Jane. I was really impressed by the 97% of first attempt accuracy for the guide wire the wire placement. I think it's in Europe, in France, we will have two main concerns to develop more this technique. The first one would be the cost effectiveness analysis. If you want to use this in our hospitals, and our clinic and our centers will ask us how many scaphoid are necessary to operate by year to invest in this equipment. That would be our first problem to develop this technique. And the second one is the analysis of the radiation exposure. I think Bo and for the authors, did you think about comparing how the radiation is reduced using the robotic technique? And one of my last question would be, in the future, do you think we can imagine using this technique completely fluoroscopy free, for example? That would be my question for you, because it's really, really impressive for the simple cases, and also, as Jane told us, for the difficult cases, the proximal pole cases, and all the non-union that are really difficult to use. Because now the traditional technique gives us very good union rates. So we need to think how we can really use this technique in other difficult cases.
Yes, thank you. Maybe I can answer this question. So, yes, Dr. Yi, I just mentioned that we are using both robotic surgery and freehand surgery. But the reason now in my center, the reason we still use freehand surgery is we do not have enough robot. So, so all my young generation, they really love robots. So nowadays, when I doing a scaphoid non-union arthroscopic bone grafting, after the bone grafting part, I will unscrap. I will let my resident to do the fixation of the scaphoid, because the resident like the computer games. They just planning on the plane, and they just press the button, the robot will do the rest of the things. So the only thing we still use freehand is we do not have enough robots. So we need to actually get up early in the OT day to get the robot before others, so we can use the robot now. So I think this is as you can see in the future, if we can have more and more robots, and the cost will be going down. And all the cell phones. So now 10 years ago, our smartphone is very expensive, and now the price for conventional smartphone is going down and down. So I think with the technology is keep involving the price of robots, the cost of the related cost will be going down. And also, this kind of a robot actually is not used just for hand arrays. It can be used for all the orthopedic procedures, like the spine, like the joint, like the radius fracture, the elbow fracture, whatever. Whenever you need a tool to help you to accurately locate the trajectory of the implant, you can use this. So in this way, if a hospital just buy this kind of robot, the cost will be actually shared by all the orthopedic colleagues. And
thank you.
When talking about the X-ray exposure, I think it is one of the aim we'd like to achieve, that so-called zero X-ray exposure. As nowadays, with this robot, actually for the surgeons, we almost have no X-ray exposure with this robot, because we actually when robot doing this way, all this work, we can just keep it not far away from the X-ray. But for the patient still have to have some kind of X-ray exposure, because we need to acquire the intra-op image of the wrist. But with the advancement of the image intensifier, so the intra-op C arm, this is the intra-op ISO C arm. Actually, the radiation dose is quite decreased when compared to a conventional CT scan. Actually, is lower than conventional CT scan. Yeah.
Thank you, Bo. If I can just ask a very last question, did you study or compare, Bo, the surgery time with the experience? Did you decrease the surgery time comparing with the traditional fixation?
You mean the timing?
Yes. Is it faster for you? And with the time, with the learning curve, is the surgery time?
Yes. So I think it's
lower.
I think if you use a robot for a non-display scaphoid fracture, I think the robot may not as quick as Dr. Alan Arnott, but it is quicker than young surgeons with young residents. I think it's
Yes.
one of the key issues. The robot can help all our orthopedic colleagues to achieve the good results even in a very unexperienced hand.
Thank you.
Yeah.
Bo, can I follow up and ask, where do you think the steepest learning curve is? Or is it the setup or is it the technical procedure? If someone is looking to start this in their department, where would they need to focus their attention?
Yeah. Thank you, Matt. So I think a setup is not a big deal because it's not very technically things. So when you get more and more familiar with procedure, the setup time can like less than 10 minutes. So I think in the future is actually Greg has mentioned before that or also Jane has mentioned before, so in some complex fractures like displaced fractures with DC deformity in old fractures. So in this situation, we need to reduce the fracture first. Either use a fluoroscopy control or scopic control. We reduce the fracture to anatomic reduction. Then we can use a robot to do the fixation. And also another thing is so with really complex fracture, because we all know that the fracture line of the scaphoid fracture is not a single line. Actually, it's a plane. It's a plane. It's not a line. So if we in the future we really need a so-called fracture line specific fixation to achieve best to achieve optimal mechanical benefit of the fixation. So the robot can help us to analyze the fracture plane and to plane the right way straight across the plane to help us to get the better mechanical benefit of the fixation. So I think in the future, AI can help us to actually analyze the fracture line, fracture plane, and to calculate the best way to do. And the surgeon just need to select the best way, and let the other things the robot will execute the rest of the things.
Thank you, Bo. I'll come to Jane. She's got a hand up, and then I'll ask Greg for his thoughts. Jane?
It was just a general remark, actually, Matt. When you look at the illustrations in the paper, this requires quite extensive wrist extension of what looked like 90 degrees illustrated in the paper, which no Pfeiffer, no Scott has. We have about 60 to 70 degrees of wrist extension. And for that reason, we usually have an entry point in the trapezium rather than on the scaphoid. So have you any comments, Bo, about how you would go about this? Would it be easy to use the robot if you had a trapezial entry point?
Yes, yes, Jane, this is a very important question. So technically, so actually in the operation, we really need to like we do the freehand, we need to fully extend the wrist to actually allow the human hand to get the entry point, and also same thing for the robot. We need to the robot hand to got the to directly to the scaffold. So you really we have a in the robotic surgery set we have a set to actually hold the wrist stabilize the wrist in extension position, and we stabilize the wrist together with the patient tracker, the tracker that the robot can see together with the like a special like a splint to help the wrist in the extension position. But for other procedures, like nowadays we use the robotic to help us to do the four corner fusion, other implantation of the wrist. So we can choose a different position. We can use different jig to help the wrist in different way of immobilization in the operation. Yeah.
Thanks, Boo. Greg, I'll ask for your thoughts, and also just the wider future of robotic surgery for the hand or wrist, where you see the journey going. Thanks.
So at the moment, I think it has to be just in very specialist centres where they're able to provide that support, and you've got high quality surgeons and a good funding resource. So I think it'll be quite limited. In my city, there are some robots that are used for prostate surgery. I have seen them used for the reflux as well. So there are some cases like that, but I don't think I'm likely to be invited to do my scaphoid fracture next week with the robot. I think there'll be other people in front of us. But I actually wanted to ask a couple of questions if I could, or make it firstly a comment was about the learning curve. I'm really grateful to get a feel for what this learning curve is. Now, remember, this is not a complex fracture that you're showing. It's a simple fracture, but it does involve you using a technology that you may not be so familiar with. So I think you said 10 to 12, and you make a very good analogy about the spine surgery that they have to do 25 supervised. And Jane mentioned the SWIFT trial, which I thought was a really important piece of work that probably demonstrated that scaphoid fractures should be managed by specialists and not by the trauma guy who's on call. But what we know from your work is you need to do 15 of these for a simple fracture with a robot before you're hitting your learning curve, and maybe a bit more to be safe. So I just want to make that comment, and maybe Jane or others can reply to that. And then the other thing I want to say was I think there's two tricks here. No, I shouldn't say tricks. One's the robot, but I think the use of the CT style images or the planar fluoroscopy, coronal sagittal that you've got when you're doing your scaphoid. In my practice, I use a portable fluoroscopy unit, so I might get the right plane. Then I've got to move the machine or move the wrist, and I can lose that position. So in my practice, I'm nowhere near 90% single shot wire, but I think it's partly these other things. So I want to ask you whether you've been using that CT style fluoroscopy that you've got and not the robot, and how effective you are when you're using that technology, because I think that is an important part of the whole concept you're presenting here. And that's something that I think I actually can get in my hospital, because I think our cardiologists use something similar. It's a dual fluoroscopy unit, I think, where they rotate it, and then the computer puts together the plane. So Bo, maybe if you can comment on the role of these new, more advanced fluoroscopy units.
Thank you, Greg. So wonderful thing, because so I love your question, Greg. So you always inspire us with new things. So I think it's actually, yes, before we use robot to do the scaphoid fracture, we try navigation surgery for scaphoid surgery. So in that way, we use this like CT scan like CR. So we have a three-dimensional map of the fracture, and then we use navigation guided surgery. So we still like this navigation system helps the surgeon to know where your trajectory of the screw and where your entry point is to, and you do it freehandly. So I think it's yeah, like you said, it's great to get this 3D view or that like in a better view of than the II. So but then when we move to use robotic surgery because because even with the navigation, so the shaking of the human hand is inevitable. So for larger bone like spine, like pelvic, it's okay, but for scaphoid bone, the human shaking of hand may not be acceptable in some time. So robotic surgery actually, like we do the robotic microsurgery, like one of the advantages to reduce the tremble of the human hand. Yeah.
Thanks.
Thank you, Greg. Thank you.
Yeah, thank you. That's a really great question. Bo, where do you see the technique affecting scaphoid non-union or more displaced fractures beyond what was featured in the paper?
Yes, so I think it's we have a more the robotic surgery can have a more role in hand or wrist surgery, including union, including displaced fracture. So we can also use a combination of the wrist arthroscopy to achieve mini wrist surgery for all this situation. Like we can do the arthroscopic bone grafting for old fracture. We can do the arthroscopic assisted reduction for the displaced fracture, like I use this. I also use this for perineal injury, grossly displaced scaphoid fracture, and I reduce it arthroscopically and temporarily fix with a KY, and then we proceed to robotic surgery for definitive fixation. I think this is how we expand the use of robotic surgery from undisplaced to displaced or and also we can do a discrete fracture with a fragment specific fixation for discrete fracture in a mini vertebrae, and we can do this for corner fusion, for fusion of the or partial wrist fusion, for anything in hand wrist. We need accuracy. We accurately putting a guide wire or putting a screw, etc.
Thank you, Bo. Ronit, Dr. Wollstein, you have your hand up.
Yes, thank you. I think one of the things that have always worried me with this is the position of the wrist, because as we move the wrist when we do anything freehand, the scaphoid changes its position. So like was already mentioned, you have the wrist with the robot in a very specific position. But if we do navigation, is it possible to adapt the position and hold it in order to get an accurate fixation or accurate placement of the K wire or the screw? So it's kind of a technical.
Yeah, thank you. This is really technical. But it's a very, very important question. So no matter you use navigation surgery or robotic surgery, you always need the wrist. You need to stabilize the wrist when you're doing the surgery, because when no matter it's robotic surgery or navigation surgery, you need the robot. You need the robot know the location of the hand, the location of the wrist, location of the carpal bones. So you need to actually stabilize the wrist, and you use the patient tracker. It's a small tracker actually while allow the robot know the location of the wrist. So you need to stabilize the wrist and stabilize the tracker together. So the wrist and the tracker together became a rigid body and cannot move, so that the robot can understand where he or she need to go.
Thanks.
Fantastic. Thank you. Thanks for that question. Thank you, Bo, for the answer. We can return to this paper, but I think in the interest of time, we will move on. I'll pass over to Rebecca.
Okay, and so now we are going on to the final paper of our combined journal club. I'd like to call upon Dr. Andres Mena and Dr. Ronald Wollstein from the USA to share their paper on the finite element modeling.
Hopefully everyone is seeing the screen right now.
Yep.
Perfect. So thank you. Hello. Thank you for the invitation. I will briefly talk about some of the topics covered on this paper titled Finite Element Modeling of the Human Race, a review. So let me just start with some of the fundamentals here. Despite the race being fundamental for many activities of daily living and other leisure activities, of course, consequently being exposed to a high number of injuries and pathologies, although that motivated this review was the study of wrist biomechanics by itself, which is largely unexplored. There have been some enormous efforts to, of course, decipher wrist mechanics, but in general, pathology and treatment research is limited, mainly due to the lack of a healthy baseline. So these three topics are very important. Now we'll just go back to what the healthy baseline is, what authors have done to define a healthy baseline, what authors are doing to study pathology, and how both healthy and pathology models enable the study of treatments. Now, the way wrist mechanics have been determined, similar to other fields, is just using the gold standard, which is cadaveric studies. However, there are many limitations when it comes to cadaveric studies, to these experimental studies, mainly due to the fact that soft tissues do not replicate in vivo conditions. They are definitely not easy to arrange, as you may see on the screen. And once the test is done, you cannot use the same specimen to just repeat the test. And regardless of them being cadaveric studies, it's still really complex to measure internal variables. That's when computational biomechanics sort of come to the rescue here, since they overcome the limitations to measure some of these internal variables. And there has been some success on other fields like hip and knee and dental implants. So the main advantage of computational biomechanics like finite element analysis is that they are a powerful tool to predict the mechanical response of the system. And so the goal of this review was to summarize the advances in finite element wrist biomechanics during the last decade, which at that point was 2012 to 2022, and then recognize and categorize some important parameters, some challenges and pitfalls that other researchers have found, and of course, identify current and future research directions. No. Just as a really brief introduction of the method, the way FEA works is that you decompose a really complex problem or geometry into simpler shapes, like what you can see on the left on the screen right now. Then you assemble a mathematical model that incorporates the simulated actions, other relevant material properties and contact. So the simulated action, like let's say grasping, is represented within FEA with something called loads and boundary condition. Then you solve the mathematical model, and then you obtain the response of the system that you can see on the right of the screen. And the way authors have done it during the last decade is basically the same three-step process. You first start by acquiring the geometry through some sort of medical imaging format to obtain the 2D geometry, thus building subject-specific models, then do some bone modeling aspect, which is actually converting the mesh or the elements that I just mentioned during the last slide. And of course, depending on the material that you want to represent, let's say for cortical bone, you would want stiffer material, and for clavicular bone, less stiff material. And then finally, for most of these papers that we found, some soft tissue was added in the form, of course, of cartilage and ligaments. Those ligaments were simplified due to the lack of material properties using springs that you can see on the right on the screen, and cartilage mainly using thin layers with multiple shapes, multiple thicknesses, depending on the methodology used by that specific paper. Now, some important remarks when it comes to the three categories that we explained at the beginning. When it comes to the healthy model development, most of these papers just consider static actions with a really small sample size, mainly due to the fact that developing a model takes a really long time. As such, there were multiple challenges, divergent modeling techniques, a lack of a standard validation, and of course, untested actions because different papers were just using different actions. Soft tissues material properties, particularly ligaments, were largely underreported. That was an issue then to replicate some of the actions for the future, and tendons and muscles were almost never included in any models. Here you can see just one example of one of the foundation models that was cited a lot. just using grasping loads and the contour or the response. For pathology models, really scarce papers, but most of them dealt with some form of arthritis. But the main question towards the future is how to modify normal models to account for risk disorders. So what the authors did in most of this model was to modify somehow the soft tissues like ligaments, like removing the number of the springs or just increasing the distance between bones to account for some sort of deviation from the healthy baseline. And finally, for the treatment models, this is just one example, including one of the implants. Most papers that we found dealt with arthroplasty. And of course, there is some potential to test subject-specific solutions since you can tailor the implant to the specific geometry of the person, but it is severely limited if you do not have the geometry of the implant or if you don't know the right person to then implement that into the model. But with that being said, I just want to thank you for your attention after just looking at this slide, which is the conclusion. Most importantly is that risk computational models serve as a powerful platform to investigate risk biomechanics. Since you can provide a virtual testbed to overcome the limitation of experimental studies, you can definitely test what-if scenarios. You can perform to some extent virtual surgery to benchmark some treatments. And of course, you may study geometry, subject-specific biomechanics, and predict population responses once you have enough models. So thank you so much for your attention.
Thank you, Dr. Mena, for that very excellent overview. Before turning to the panel, I'd like to invite Toshi Nakamura, our editor-in-chief of Journal of Wrist Surgery, to comment. So I think this review has clearly resonated with the reader. So from the perspective of JWS, why do you think it became highly cited? And do you think what do you think of this growing importance of biomechanics and modeling in wrist surgery?
Thank you very much. Thank you, Andres, and also Ronit, to submit this paper into the Journal of Wrist Surgery. I think that we actually have the two surfaces of the biomechanical study. One is the cadaveric studies. Then also that the JAZ one is a computer simulation. Then that's I mostly done in that cadaveric studies, and that I think that there is an advantage and disadvantage for the cadaveric studies as well as computer simulations. You actually did the compare the many methods which was published in it in the previously. Then that there was a landmark about how to use it. Mechanical properties inside that FEM, and also that how to make meshes and also three-dimensional meshes or anything. There was a very good actually that textbook for that new researchers that they can actually use it that try to use in the FEM. Then this is a very good textbook for the new researchers. So that is why that I think this paper gathers many citations.
Thank you, Dr. Toshi. So we'll perhaps move on to the expert panel. Maybe, Greg, you could share with us your comments about this paper and your own work.
So, yes, and I think this is a very important paper, and it's going to continue to advance in this area. I think it's a little bit like Jane was saying with Baus' paper. That was a proof of concept that he can actually do all that concept. With the finite element analysis, I think we're almost there, and it's going to continue to improve. Ronit's obviously working in this area, and I think that as time goes by, this will be a critical thing to help us understand how the wrist works, and probably more importantly, how it also fails. We all know that we're challenged to understand what the natural history is of some of these conditions. And I think this sort of finite element analysis will actually help us advance. So although in the wrist there's not much done on it, I think in like motor vehicle accidents and in also in the hip and other areas, that this is much more evolved than it is here. So I expect that Ronit and her group and others may be able to actually really take this and create something that's really helps us advance in this whole understanding of the wrist. So thank you for the paper and teaching us a bit more about it.
Okay, thank you, Greg. And Alam, would you like to share with us your thoughts and comments?
Just a short comment. Thank you. Thank you for presenting this paper. It's very interesting. I find this concept very seducing because I think we will be able in the future to test a wide range of pathology for ligament injuries, which is not really possible for the moment. Ligament injuries, everything for arthritis is not really completely possible for the moment with the cadaver models. So I'm really seduced by the concept, but what we can see for the moment, I think, is that even with the more sophisticated models, it's still approximation of the reality. So what I feel that for the moment, the cadaveric models and the FEM are really can be complementary because I think it's for the moment I feel the cadaveric models are very important. All the biomechanical studies, and in the future they can be complementary to improve this FEM. But I'm really confident about the use of this in the future. It's very, very interesting. Thank you.
Okay, thank you.
Can I answer or just
Yes, please.
give a comment? Yes, we make, it's incredible how many assumptions we make when we build or when we work on one of these models, and it's due to the fact that we really know very little about the ligaments, their characteristics, even their anatomy, because there's so much variability between wrists that some people's ligaments insert in different areas, I'm sorry, on the different bones. And so this is still, and I totally agree, this is still very, very preliminary. And the problem, though, with the wrist is that the ligaments are so important, and cadaveric studies are quite poor in characterizing the ligaments, right? First of all, the anatomy is not good, and secondly, the characteristics are different from in vivo ligaments. So I think that's a field that we still really are struggling with, or a part of this that we're still really struggling with. And we're actually working on, or trying to work on, using ultrasound to characterize ligaments in any given wrist. And the advantage of that, and this is also new technology, and I'm not an engineer, but the thought is that we'll be able to actually characterize ligaments anatomically and physically within any given wrist. And so that's sort of a part that we are working on now as to add to our current model. And we have been working on this and refining it for a very long time. Maybe Andres can say something also about sort of where we're going with this. But I totally agree. It's astounding how little we know.
Yes, we have a couple of hands up. Alam, would you like to say something?
Yes, just a very last question. I'm really seduced by the concept. Do you think we will have the opportunity in the future to have a clinical application? For example, do you think it will be possible with some research to have, for example, a patient-specific FEM to be able to have an accurate treatment do you have any comments about this? Because we are only in the field of the research for the moment.
Absolutely. That's the whole idea. That's my I don't think it will be in my lifetime necessarily, but that is certainly my thought or my incentive for doing this. I think that is exactly what we will need to do, is to take a wrist, maybe get a CT scan or an ultrasound, something that may not be so invasive, and be able to predict how this wrist will react to forces. We can take an athlete. I mean, okay, this is very far-fetched, but take an athlete and teach them how to best throw, for example, with given his or her specific anatomy and characteristics, how to prevent injury, how to treat, injury. This is absolutely, that is our ultimate goal.
Okay. And we've got a couple more hands. Toshi, you would like to say something?
Yeah, I'd like to talk about an FEM model has a black box that was many things that are coming from the textbook about especially about the mechanical property of the ligaments, also that the elastic modules of the cartilage, all of those things was coming from the textbook. So that is why that we can select and some of those pick up. Then there is good data, we can use that. There was bad data, we don't actually throw it away. So that is actually disadvantage for that FEM model analysis. However, that I actually very pleased to hear about that. No need now using that ultrasound to checking with an elastic modules or anything about the ligaments or maybe cartilages. So
Yeah,
that's that is a very good news for me. Thank you very much.
Thank you.
Okay, and Dr. Mena, you got something to say.
Yes, actually, just one comment regarding the subject-specific question. One of the strengths of FEA as a field is precisely the fact that you can tailor the response to specific geometries. So since you start from one a specific CT scan, the bone geometry will have a subject-specific response. Then how much material properties you can obtain is the second part of the subject-specific part. Because you can definitely obtain mechanical properties from the CT scan itself, but then you must complement that with a soft-tissue response. But towards the future, I believe the subject-specific response will be even more tailored than it is at this moment.
Oh, and yes, Jane.
Yeah, sorry, it's just a point that this looks like a snapshot technology, and when you dial in time, all sorts of more interesting things happen to ligaments and stress relaxation and how ligaments respond to force. So I see this as being something that with time is going to require far greater computational power and far more complex models. And maybe that's one of the ways we can use AI to help us over the next few years with this modeling.
Yep.
Thank you for that comment because we mention AI once every 4 meetings that we have, but because it is so complex. But I think the problem now is that we don't have enough information to feed it yet.
Okay, and Bo, you have your hand raised.
Yes, so I will echo with Jane actually, because the raised joint actually is one of the most complicated joints. So we have bones, soft tissue, ligaments, cartilage. So it's like actually I think it's I have a question for you. So that's wonderful paper. So do you think you mentioned the ultrasound? So we have a modality for bones like X-ray and CT scan, and we have ultrasound for soft tissue, and also we have MRI for actually have a better delineation of the ligaments, soft tissue. So you use like some kind of a transmodal registration technique to actually combine all these imaging modalities to get a whole picture of the wrist. And I think it's like Jing had mentioned, I think the AI definitely have a role in this, like this kind of a transmodal registration work. What do you think?
Andres, you want to answer that? Because we discussed
Well,
No.
I guess for image registration, what we typically do at the moment is just use CT scan. I have not seen any work that superimposes both CT scan and MRI at the same time. But definitely that could improve the fidelity of the model since you can account for both the bone and the soft tissue part. But that would be like a great idea towards the future and how to improve the models. But unfortunately, I have not seen many models using MRI scans.
But in our proposal for one of our proposals for ultrasound, for the ultrasound technique, we will try to compare to MRI. So we are trying to I don't know, juggle, but to use all of these modalities. The main issue with MRI is that it's static at this time. And ultrasound does have the ability to capture dynamic information.
Yes, yes. So
That's a
it's
great,
wonderful to
great.
mention this because we like ultrasound is dynamic, but like MRI, although it's static, but it's a better definition of all the soft tissues. I think it's wonderful if we in the future we can use this, like any kind of a transmodal registration technique, yeah, to combine all this. Thank you.
That's a great idea. Yeah. Thank you.
And Greg, yes,
So
can we hear
the
from you?
the other thing that we've found quite useful is the 4D CT, so it enables you to see the wrist moving in real time. That might be part of the trick to add to it. And then the final thing is our university actually did some finite element analysis on the scaphoid and of an individual falling onto their wrist. And so I looked at the models they had and I thought, I don't think I've ever seen a scaphoid fracture look like that. And I said to him, did you put any ligaments on it? And he said, oh, we didn't know that we should put any ligaments on it. We didn't think the ligaments would be important in the wrist for a scaphoid fracture. So really the message is that we as the clinicians, we see cases all the time and we understand the anatomy hopefully a little bit better. I think we need to keep engaging with the engineers. We certainly can't do it without them. And I think the only way it can be really good is if we help them, but obviously they got to lead it because it's the basic science of engineering and things. But we need to make sure we at least have a foot in the camp. And Ronita, I think it's great that you're involved with their clinic and helping them do this new advanced science.
Thank you.
Thank you. And I'll hand over the stage back to Matt for the closing remarks. Thank you all.
Thank you, Rebecca. Thanks to everyone. We're all on this webinar because we're interested in wrist surgery and providing the best possible care for our patients. We've had 3 really progressive papers presented today. They've been wonderfully clearly presented, and we only progress through research. So thank you to the authors for getting these to publication and having the initiative to advance our specialty, and also for your clear presentations. We'll finish by asking the 2 editors-in-chief, firstly Jane and then Toshi, to just give some thoughts and closing remarks on the 3 areas we've heard in this webinar. Jane?
Thanks. Commenting on the papers from the European Journal, I think we have got some good areas for further research defined by these 2 papers. Firstly, with the arthroscopic inside out, we want to see a cohort analysis with a comparator rather than just clinical outcomes from one technique without a comparison group. Secondly, with the scaphoid, this is really exciting where this is going, and we're all looking to Beijing to provide a lead for us in this area. I think that's going to be very, very slow to implement into the NHS in this country, but the more evidence that comes from other countries, then the more we have to kind of use with our managers and healthcare providers to try and invest in hand surgery. So thank you to both the authors of these papers.
Toshi?
Yes, that the Journal of Wrist Surgery are still accepting that the biomechanical papers, so that we're going to gather that many papers about the biomechanical basic sciences, and also that Journal of Wrist Surgery also welcomes that many papers, procedures, such as that today's topic about TFCC foveal repair or robotic science, robotic procedures. Thank you very much.
Thank you, Toshi. Thank you, Jane. So on behalf of Rebecca and I and our respective societies, we'd like to thank everyone who contributed to today's webinar. Our experts from across the world, Australia through France, our society representatives, Bo and we, and our editors-in-chief, and of course our authors. It's been a great discussion. This will be shown as a recording on a number of websites, including, I'm sure, the APPA website and the BSSH and Journal of Hand Surgery websites in due course. Nothing much more to say other than good morning, good afternoon, good night, and thank you for joining.
Thank you.
Thanks for a
Bye-bye.
great webinar.
Bye,
Thank
everyone.
you.
Thank you.
Bye.
Thank you.
Bye.